first just wanted to say it's such a pleasure to be here, and it's incredibly inspiring to be in a room with so many people that Clyde loved, respected, and learned from. It's quite overwhelming to see. So I wanted to share with you today some thoughts from work that Clyde did sort of earlier on, the pre-help years, if you will, some of the stuff that shaped, I think, some of his thinking in the last decade or so. And I actually owe a huge debt to Tom Boyce because our earlier conversations really made me think quite a lot about how Clyde thought about the world. And indeed, those of us who had the privilege of experiencing Clyde know that he really saw the world as a laboratory, and he thought about real problems in the world as something that we could learn from and in order to develop solutions that would help find our way forward. And so what I'm going to do is take you through a little tour of some of the real world problems that he sort of grappled with and that I think really informed his vision of biological embedding and why he thought experiences were so important in shaping our health and development. So when I first met Clyde, he was heavily engaged in trying to understand the causes of the rapid increase in adult deaths in Central and Eastern Europe following the collapse of communism. And that crisis, as many of you probably know, was so large that the mortality rates were so high so suddenly that they really rivaled the kinds of death rates you would see in countries that had infectious disease epidemics, except there was no infectious disease epidemic. And so the task was to try to figure out what was going on, what was causing this rapid surge in adult death. And so with other scholars, including Michael Marmot and Martin Bobak and others, we began to work to hypothesize what could possibly explain such rates of death. And we observed a couple of things that were going on. This top graph shows Gini coefficients of income inequality across countries in Central and Eastern Europe across the years sort of just preceding and following the collapse of communism there. And the bottom table shows some measures of lack of trust in institutions, whether or not you trusted church and religious organizations, police, civil service, military, and other sort of formal sets of institutions that were present in society and being built. And the patterns that emerged suggested that the adult health crisis was probably a function of a rapidly set of changing societal institutions, and that change, that sort of economic and social shock actually manifested itself through stress processes and resulted in these very high, very dramatic mortality rates. The complexities in this case were tremendous. First of all, you had a whole set of factors that were happening, things like income inequality, things like trust in social institutions. There was variation across countries. There was variation across years. And Clyde, it will always hit me deeply, very much saw these variations as something not to be controlled away, but to be understood. And that's one of the things that made him a unique scientist. I think very often we seek to sort of isolate causal factors. Clyde saw that variation and that complexity as part of what built a true and rich story and created deeper understandings. Well, as the work we did on how societies affect health continued, we turned our attention to a problem much closer to home, not on the same scale as the Central and Eastern European mortality crisis, but equally as perplexing. And that was why was there persistently higher life expectancy in Canada than in the United States? Why in two such similar economically advanced and stable nations would one have a health advantage over the other, and a persistent health advantage at that? And it turned out that health insurance was not the answer. the answer was not that we have universal health care in Canada and they don't in the US, and we knew that from a mounting set of studies. And so what else could be going on to explain that difference? And our work on this project was actually one of the first times that I really saw how meaningful and necessary CIFAR and CIFAR programs were to Clyde's intellectual development, and then, of course, to my own. Early on, we took this very graph that shows life expectancy differences of men and women in the two countries to one of the earliest Successful Societies meetings, and basically stood in front of a room of brilliant scientists from every discipline but our own, and asked, what do you see in these patterns? What might explain these kinds of patterns between two such similar countries? And in the end, through discourse and reflection on prior literature, we arrived at a hypothesis that said it was social spending and public policies that dictated the distribution of resources that trumped things like spending on healthcare, that trumped things like economic growth, which the US also excelled at, and actually even trumped things like unemployment rates. And that social spending and public policies were responsible for creating the kinds of environments, the schools, the neighborhoods, the family environments that shaped daily experiences and therefore explained health. And in Clyde's eyes, I think the Canada-US story, unlike the sort of economic shock, drastic story of Central and Eastern Europe, was one where you can see how graded differences in societal conditions make graded differences to health. That is, it's not just at the extremes of institutions and the extremes of experiences that we start seeing differences. It's actually incremental, as Neil pointed out in his presentation of the gradients work. And one of the sort of propositions that underlie our early work on Canada-US comparisons is that the average differences you see may very well result from differences in the socioeconomic gradients in health. In other words, averages are born out of the extent of inequality. And we hypothesized that because we thought experiences shaped these average differences, and experiences themselves are socioeconomically determined, that socioeconomic gradients may also be different between Canada and the US. So as Clyde went the epigenetics direction over time, I stuck with this stuff with other colleagues and have started to produce a set of studies, as have many others, which look at the extent of difference in socioeconomic inequalities in health in Canada and the US. This is a graph of racial disparities in Canada and the US amongst people who were native born as opposed to being immigrants across a variety of health outcomes. And you can see the sort of lighter gray graph bars are the US, the darker ones Canada, and on a lot, but not all, of these health outcomes, you can see the US has a much higher white, non-white disparity than you find in Canada. Recently, we've also turned our attention to trying to understand the relationship between socioeconomic status and body mass and its variation across Canada and the US. These are results for differences by income quintiles. And one of the things we're finding is that the nature of socioeconomic disparities actually varies on several scales. The size of the gap matters, but so does the extent of the distribution to which inequalities penetrate. So there's these multiple complex differences across these two seemingly similar economically advanced countries that seem to really be at play. So all this to say, there was a set of world problems that I think Clyde processed as being examples and tales of what causes population health patterns to be the way they are. And I think what layered onto that was his biological understanding of the sensitive periods in early life. And he put this kind of evidence together. As many have said, he was able to put pieces of the puzzle together in really amazing ways. And so putting together the information about societies and institutions with what he knew about early child development and human development and biological embedding, we produced this framework for the World Health Organization's Commission on Social Determinants of Health, which essentially says what I've just sort of stated in more general terms, which is that human development and human health are a function of the many environments that produce everyday lived experiences, and that they're all interconnected in ways that can create inequalities in these experiences, and therefore inequalities in outcomes, or lead to more egalitarian distribution of experiences and outcomes. With just a few seconds remaining, I just want to close by saying that this work really was done in ways that are very tried and true to Clyde, which is that they were incredibly collaborative and relied heavily on interpersonal meetings and dialogues with a variety of scientists. And I think Clyde's sort of way of working was this sort of interpersonal, over time development of ideas. And he found this incredibly stimulating, incredibly essential to his work. And I would be remiss if I didn't say this, because I think in recent years he had expressed some concerns about the direction of major funding agencies and the inability to really sustain these kinds of models, and just how important they are to the growth of ideas of this nature, of big ideas, of transdisciplinary ideas. And I think Clyde showed by example how much investments like that truly pay off. Thanks.